Introduction to Human Anatomy. In this lecture, we hope to discuss the importance of learning human anatomy or about human structure. A doctor should be able to get an idea about the organ or the tissues affected based on the symptoms and signs of a patient. Symptoms are the complaints by the patients. If a patient comes and tells a doctor that he is having headache, abdominal pain, chest pain, backache, constipation, those things are called symptoms. Signs are what the doctor elicits from patients after talking to the patient, taking a history about his illness and examining the patient. What do you observe here? There is a man holding the right side of his abdomen. He seems to be in pain, and the pain could be moderate to severe pain. What else can you decide by looking at this person? This person could be middle-aged and he is holding the upper part of the abdomen close to the lower part of the right side of the chest. Based on your anatomy knowledge, you can guess that this person might be having a problem with his liver, gallbladder, right lung, right pleural space or the pleurae, or even the tissues surrounding these internal organs like the rib cage or even the muscles. Having that in your mind, you should look at the condition of this patient, take the history from the patient and examine the patient. What do you observe here? Now, this is a lady, fairly young lady, holding onto the lower part of the abdomen on the left side. In contrast to the first picture where you saw a male, in the second picture, when a female was holding onto her left side of the abdomen, the lower part of the abdomen, the organs that comes to the mind of a person who knows about the structure would be the female reproductive organs first. So it could be the left fallopian tube, left ovary, or it could be other things like which is general to males and females, could be arising from the ureter, maybe a ureteric stone, or it may be the pain arising from the sigmoid colon of the GI tract, which is located on the left side of the lower part of the abdomen. Now observe these two pictures. On the left side, you see a patient with a swelling or lump at the back of his neck. Immediately when you look at this picture, you will think of a condition arising from the skin, subcutaneous fat, muscles in that area, bone or ligaments. No other important organs at the back of the neck in that area. When you look at the picture on the right side, you see a huge swelling or lump of the person in the lower part of his face below the right ear. In contrast to the previous picture, the moment you see this second picture, you think of the parotid gland, one of the salivary glands in that area. The shape of the lump and the location of the lump indicates that it could be arising from the parotid gland. Then it could be arising from other structures like the mandible in that area and maybe sometimes lymph nodes, but it's very likely that it's arising from the parotid gland. Further investigations need to be done to confirm that tentative diagnosis. Now I will give you a task. You should do this task at home as a homework. List some other symptoms the patients are having. Symptoms that will bring a patient to a doctor. List some signs of patients that the doctors will elicit. Then it is also important to know human anatomy when it comes to procedures like withdrawing blood or giving injections. You can see several pictures here. In the first picture here, you can see a healthcare worker is withdrawing blood from a patient. Now in this area, there is an important vein called median cubital vein. This person is withdrawing blood from that median cubital vein. Again, here you can see an intravenous injection. The drug is inserted into a vein as a means of treatment. Now again, this intravenous injection is given into this median cubital vein here. So knowing about the structure of veins in this area is important for you to perform these tasks. And here in this picture, you can see a blood transfusion. Usually the blood transfusions are given into the cephalic vein here. This is on the lateral border of the forearm. Then in this last picture, fourth picture, you can see an intramuscular injection. An injection is given into a muscle. In this case, it is the deltoid muscle here. But remember that this injection is given little bit lower than the usual site. It is better if the injection was given somewhere here, because the muscle is like this. So having knowledge about the shape and the extent of the muscle will direct you how to give the injection correctly. And this needle the person has used here is little bit large for this purpose. Then there are other important basic medical procedures. In the first picture here, you can see a nasogastric tube. A nasogastric tube is a tube inserted through the nose into the stomach. You can do this to feed a patient who is unconscious, who cannot take things orally, or you can put this tube to relieve the pressure of the stomach, or if there is vomiting, and if you want to prevent vomiting by taking gastric contents out, you can put this nasogastric tube. You need to know the structure of that area before you inserting this nasogastric tube. There's a certain way you position the person, position the neck of the person and the jaw of the person to insert the nasogastric tube. And the length of the nasogastric tube is also calculated based on the knowledge on anatomy. And in the second picture here, you can see a urinary catheter inserted into the bladder. This is to relieve an obstruction in the urethra, which is here, urethra of the bladder, which is called bladder outflow obstruction. Or you can do it in an unconscious patient to prevent bedwetting. You can put a catheter and connect it to a bag so that urine will get collected there. What are the other reasons why you need to learn anatomy? Many of you in this batch, once you pass out, you will do postgraduate exams to become surgeons, and you will do a job related to surgery. Surgeons need to know what they cut. They should know where to cut, and they should know where to find organs and structures in the space that they have entered. Could be the abdomen, it could be the thoracic cavity, or it could even be the cranial cavity. They should know where to find the structure that they are going to find. And they should know, in the process of doing that, they should know the relationship between structures and organs. Which structure is in front of it, which structure is behind, above, below, laterally, or medially. Without knowing that, if they start cutting, they will damage the structures surrounding the structure that they are going to remove. Then the doctors, especially the surgeons, need to know normal variation of structures. Now, people are not 100% alike. There are very slight differences. Blood vessels, nerves, or veins can be in different places sometimes, which are called normal variations. That is not an illness, that's why you call it normal variations. So when you cut organs and structures and tissues, you should know the variations, otherwise you will cut the wrong structure, or you will not be able to find the structure that you are looking for. If you don't know the variations, you might not be able to find where you usually try to find it. This is a simple example to show you a surgeon's anatomy knowledge. In this image, it is drawn to show you a surgery which is called cholecystectomy. Cholecystectomy is removal of the gallbladder, most probably due to stones inside the gallbladder. You can identify certain organs here. You can identify the liver here. The liver has been lifted up to show its undersurface or the inferior surface, and attached to its undersurface or the inferior surface is the gallbladder, which this person is going to remove now. Now the gallbladder has a duct called cystic duct, which brings bile secretions from the gallbladder out, and this is called common hepatic duct, which brings out secretions from the liver, left and right lobes of the liver, and this is called cystic artery. Cystic artery is the main artery that supplies the gallbladder. When the gallbladder is removed during cholecystectomy, the surgeon has to identify the cystic duct and tie it on either side and cut it in the middle so that there will be no leaking. At the same time, they have to identify the cystic artery here, tie it on either side or ligate it on either side and cut it in the middle here. So this is what the surgeons do. Now, for them to identify the cystic artery, which is an important artery in that area, if you don't ligate it properly, there can be bleeding after the surgery, which is very dangerous. So to identify the cystic artery, it is important that the surgeon knows about the Kellogg's triangle. Kellogg's triangle is an area defined by the cystic duct lying laterally. This is lateral side, this is medial side, and the common hepatic duct lying medially, and the inferior surface, this surface of the liver, lying superiorly or above. So this triangle is defined as Kellogg's triangle, and within that triangle you can find the cystic artery, as you can see in this case. So it's easy for the surgeon to find the cystic artery if he knows the Kellogg's triangle. So that's a very nice example of their anatomy, the importance of their anatomy knowledge. Subsections in the study of anatomy. Macroscopic structure or naked eye appearance of organs and tissues is done during gross anatomy dissections mainly. Sometimes we use dissected specimens, which are called prosected specimens, to show you the macroscopic structure or naked eye appearance of organs and tissues. Then when you can't see the structure of the tissues and cells through the naked eye, then we use microscopes, which is called microscopic anatomy or histology. And then there is this embryology. Embryology is development of a fetus in the womb, and it is important to learn the development of different organs, because errors during embryological development can give rise to diseases later. So to know the basis of the disease, you need to know the embryology or the development of the fetus in the womb. Then comes the genetics, where you learn about the chromosomes and genes, and the problems with chromosomes and genes, and how they give rise to diseases in patients. So these are the main subsections in the field of anatomy, which you will go through during your learning process. Then the dissections, when it comes to macroscopic anatomy, the dissection based anatomy, where you cut a human body, dead body, which is called a cadaver, and learn from it, that is divided into several regions of the body, so that you can easily learn it rather than taking the whole thing at once. One important region is the upper limb, and the other one is the lower limb. So during upper limb and lower limb dissections, you spend quite some time on that, and during that period you will learn a lot of anatomical terms. You will see a lot of relationships between arteries, veins, nerves, and you see a lot of muscles, their attachments, and about the bones forming the upper limb and the lower limb. Then comes the thorax and the abdomen. So it's self-explanatory. You will learn about the thoracic cage and the organs in the thorax, and the abdominal walls, anterior abdominal wall, and the contents in the abdomen. Then the pelvis and the perineum, where you will learn about the pelvic cavity and the perineum separately. And the last one is the head and neck region. Together with head and the neck region, you will do the brain and the spinal cord structure of the nervous system, which is called neuroanatomy. This is for your information about things that you need to bring when you come for the dissections, on-site dissections, not online. Now, once these COVID issues settle someday in future, we will have an introduction to dissections on-site in the faculty, and for that session you need to bring certain things. You need to bring instruments to cut the bodies, and you need to bring things to cover the body and soak the bodies with body fluid. So the details will be told later. For the moment, we will put this on your e-notice board later on after this lecture, so you can go through these things and collect them and be ready with them for the introduction to dissection session. There will be a lecture also on introduction to dissections shortly after this one. I will upload that lecture also, but you need these things to be brought when we start the actual dissections on site program. So I will not try to read this long list. I'll show you the slides. Just go through the slides and put them on the e-notice board so that you can leisurely read them and find out the things from pharmacies or somewhere. So you need forceps, you need a scalpel handle and scalpel blade to be used with the handle, and there are certain scalpel blades that are not recommended. You can see the pictures of the scalpel blades that are not recommended, at least at the beginning. Later on, when you become more experienced, you may be able to use these small scalpel blades, but to start with you should use this scalpel blade. So this is how you see it when the blade is put onto the handle. And then you might need a scissor. It makes the job easy when it comes to dissections. And you need a fairly large forceps, 5 to 6 inch forceps. Now this forceps is a non-toothed forceps because you don't see a tooth there, it's very flat. So there are toothed forceps also where you see a tooth here, so that it's easy for you to catch things. But when you catch small nerves and blood vessels with the toothed forceps, those structures can get damaged. Therefore, when you handle delicate structures, it's important to have this non-toothed forceps, something like this. Then the other things that you need to bring, like lab coat, disposable gloves, hand wash, all these things we will put on the notice board. And to protect your eyes, it's recommended for you to use goggles. Students don't use goggles sometimes. It's up to you, but our recommendation is that you should use goggles when you dissect to protect your eyes in case you splash some formalin into your eyes. Then this blue tack, for you to do assignments, you might have to paste certain things on skeletons. Dr. Jayampati is giving a lot of assignments to you, so she likes you to have this blue tack with you, at least one per one body group. And these plastic trays and baskets and spray bottles, so that you can bring instruments between the body. You can transport instruments between the body and the washing basins, wash basins and sinks in the dissecting room without spilling water on the floor. Books recommended for anatomy. There is a long list of books that we recommend, but you need not have all these books, your own copies. there are a lot of e-books nowadays, and your generation who are more towards e-books, it's easy for you to have e-books and read them on your tablets or laptops. But you should know that all these books can be read from time to time, and different students like different books, so it's up to you. But now this Grant's dissector is the dissector that we use. It is the basic guide for students to dissect the cadaver or the dead body, and you know that we divide your batch into several body groups, about 15 or 16 body groups. So about 15 or 20 students will be in one body group, and if you have about 2 Grant's dissectors per body group, it would be enough. So one for one side and the other one for the other side, left and right sides. You try to buy the latest edition. All our references for dissections will be given from the Grant's dissector. Edition might be different, but it's from the Grant's dissector. So that's the dissector we use. In different medical faculties, they use different dissectors. Here in Peradeniya, we use the Grant's dissector. Then the Grant's Atlas of Anatomy. Grant's Atlas of Anatomy is the book with images and pictures, diagrams, so that it makes your life easy when you want to find some structures or organs when you dissect using the Grant's dissector. Grant's Atlas is like a map where you will actually see the relationship of organs before you cut and see the structures in the cadaver. Then the functional histology, the Wheatus functional histology, this is the best and the only book that we recommend for your histology learning. We are in the process, Dr. Himani Amaratunga is in the process of writing a histology book, very simplified one of her own, but it's not out yet, so you will have to be satisfied with the Wheatus functional histology. If possible, you can have your own copy, because you do histology, you do of your own, not in groups. Then human embryology, there are many books on human embryology. You have Langman's embryology, which is a fairly big book, but the best and the most simple one is the human embryology by Professor Malakanta Chandrasekhara. It's a very small book, but it includes everything that is necessary for a medical student. You can at the moment you can buy it from the you can pay 600 to the Shroff counter at the medical faculty, and you can bring the receipt to the Department of Anatomy. We can issue the book if it is available at that time. Then the last Anatomy, Regional and Applied, is a very famous book among old medical students, but this is not the main textbook that we recommend at the moment. The main textbook that we recommend at the moment is this one, Clinical Anatomy by Regions by Richard Snell, because this book it gives all the basic stuff in anatomy as well as the clinical importance of the anatomy that you learn. So this is a book, if you get used to this book, you can use this book until your postgraduate and even after that. So that's the main book that we recommend as the textbook in anatomy for your batch. Then you have other books like Gray's Anatomy for Students, which is a very simple book. Then you can have, if you want to have just clinical anatomy only book, you can have the Clinical Anatomy by Harold Ellis. But this is a fairly superficial book. It does not have basic anatomy stuff much. It's only clinical stuff that you have there. So that's why we recommend Richard Snell Clinical Anatomy by Regions. It's a combination of a textbook in anatomy and clinical anatomy. Then you have other books like Clinically Oriented Anatomy by Keith Moore, which is available in the library. You need not have a copy of your own. Don't try to buy it. It's a waste of money. Then Macmillan's Color Atlas. All these things, try to find ebooks. So whenever necessary, you can actually look at the ebook and refer it. But try to have this book as the main book and read that. We want to train you to use Clinical Anatomy by Regions. That will take you a long way in our opinion. Here at Peradeniya, we have a module-based curriculum. So these are the anatomy modules that you will learn during the 3 semesters of your work with us. A semester is a 6 months period. So in the first semester, year 1, semester 1, Y1, S1 means year 1, semester 1. In year 1, semester 1, you have two modules. First one is Foundation to Human Anatomy, where you will learn the basic genetics, and you learn the general embryology. You learn about the basic tissues and microscopy, which is a 2-credit module. Then you have the Anatomy of Limbs, where you will learn the upper limb and lower limb in the first semester itself, which is a 4-credit module. Then in the second 6 months, that is the second semester of the first year, you will have the Anatomy of the Thorax and Abdomen, which is a 4-credit module. Then in the third semester, year 2, semester 1, you will have the Neuroanatomy, head and neck, and the Genitourinary system, pelvis and perineum modules. Neuroanatomy and head and neck is 5-credit module, which is the largest module, and the genitourinary system, pelvis and perineum is again a 2-credit module. Now these modules, the anatomy modules, are other than the 3 modules each done by physiology and biochemistry departments. Then few things about your semester examinations. At the end of each semester, you will have a semester exam, and the semester exam has several components. There is an MCQ component. You will have, depending on the size of the module, you will have 10 to 20 MCQs, each answered in 3 minutes. And most of these questions are true-false type questions with negative marks given for wrong answers, and the negative marks are usually not carried to the next question. You will learn these things later. Then you have this Ospi component, where a specimen or picture is given and it's labeled, and you will have to identify certain parts that we have labeled, and we can ask questions from these labeled parts. Again, depending on the size of the module, you will have 10 to 30 questions, Ospi questions, and each answered in 2 minutes. Then the structured essay questions, SAQ, where you have to fill blanks given after a question. Depending on the size of the module, you will have 2 to 4 structured essay, structured answer questions, and each answered in 15 minutes duration. Then you have essay questions, which are long questions, which you get 30 minutes to answer, about 2 questions from each module. And then you have the last one is the Viva component, which is for about 7 minutes, where an examiner will question you verbally on certain things. Sometimes it is based on X-rays, maybe based on prosected or dissected specimens. But the bio component is not there in all the modules. It is there only in Anatomy of Limbs module, Anatomy of Thorax and Abdomen module, Neuroanatomy, head and neck and modules. Other 2 modules you don't have Viva component. Before we continue any further, I think it is important for you to have a knowledge about the basic anatomical terms that we use when we learn anatomy. We will start with the anatomical position, and we will continue from there. Now the face of this person is he's looking forward with the eyes in the horizontal plane. He's not looking up or down, he's just looking straight with the eyes in the horizontal position, and his hands are facing, the palms of the hands are facing forwards. And you can also see he's standing straight in the erect posture with the feet together. You can see the feet together here, palms facing forward, and eyes in the horizontal plane. Eyes in the horizontal plane. So his chin is also in the horizontal plane like this. So this is called anatomical position. So all the discussions are based on this position. Now in this position, I think I will remove this. In this position, the side of the face is called anterior. Side of the face is called anterior. So this is anterior side of this person. It is also called ventral, going by four-legged animals. This term has originated. Ventral is the side of the abdomen. So you can call it still, you can call it in humans also ventral, but more frequently we use this term rather than ventral. We call it anterior because we have an erect posture. Then the opposite of that is posterior. So that is the back side of the person. That is also called dorsal. That can be called dorsal, but again, the more frequently used term is posterior. So anterior and posterior is the side of the face and the opposite side, the back side. Then the head end, this end, head end is called superior, or you can call it cephalic. Cephalic means head end. Then the opposite of that is called inferior, or you can call it caudal. Caudal means tail end. So these are, these terms are coming from animals. But for us, we are more comfortable in using superior and inferior rather than cephalic and caudal ends. Caudal means that end. Then left and right, of course, you can understand that is the right side is the right hand side, left side is the left hand side. There is no question about it. Then this medial and lateral. Now later when we know about these planes, there are different planes. We'll discuss it in a moment. If you have a midline here like this, midline that separates the body into two equal halves, at least outside, then whatever that is more closer to the midline is called medial, and that whatever that is away from the midline is called lateral. So that is the basis of medial and lateral. We'll get back to it with the coming slides. Then the anatomical planes. Now, if I stop sharing and show you a picture here. Now, if you look at this skull, there's a skull with me. Now, this is the face side of the skull. If you look at the top of the skull, you can see there is a suture. These are called sutures. Joints where the skull bones are united together. Now, this suture is called sagittal suture. And if you can look here, if you pass a plane through this sagittal suture, it will divide the body, at least outside, into two equal halves. So that is called sagittal plane, passing through the sagittal suture. Since it is in the midline, it can also be called median plane. Then you can see another plane, another suture at right angles to the sagittal suture. So this is called coronal suture. This is called coronal suture. It's at right angles to the sagittal suture. A plane passing through this coronal suture is called coronal plane. I'll share the screen again. Okay, so these are the sagittal and coronal planes therefore. So the plane that passes through the sagittal suture is called sagittal plane, or it can also be called median plane. Then the other suture that I described, the frontal suture or the coronal suture, the plane passing through that coronal suture is called the coronal plane. This frontal plane is not much used, but the coronal plane is very frequently used. Then these two planes, the sagittal plane and the coronal plane, they are therefore at right angles to each other, but they are both vertical planes. Then there is a third plane, which is called the horizontal plane or the transverse plane, which is at right angles to both the sagittal plane and the coronal plane. Therefore, it has to be in the horizontal setup because other two planes are vertical. So these are the three planes that we describe. Then the other point is you can draw any number of planes away from the median or the sagittal plane. So any plane that is on the side of the sagittal plane, away from the sagittal plane or the median plane, can be called parasagittal or paramedian planes. So you can cut either exactly in the middle or you can cut away from the middle. So that plane will become parasagittal or paramedian plane. So you can use the term plane, or you can say line also sometimes, because anyway it's the line that you have drawn here. Okay, so it's either a plane like this, or it's just a line drawn on the midline. So you can say sagittal or median line, or sagittal or median plane, or parasagittal or paramedian lines or planes. Similar with the coronal plane. Then this term lateral and medial that I was trying to describe in the previous slide. Now there are two lines I have drawn here. You can see. Now again, this is the midline here. Midline is somewhere here. Then just away from the midline, you get this letter B here. And then further away, you get letter A. Now if you compare the positions of the two lines, line A and line B, since line B is more closer to the midline here, we can say B is medial to A. And similarly, since line A is further away from the midline compared to line B, we can say line A is lateral to line B. Line A is lateral to line B. Line B is medial to line A. So the basis behind this terminology is that whatever that is more closer to the midline is called medial. Whatever that is further away from the midline is called lateral. Now there is an issue when it comes to limbs, because the limbs are hanging on either side of the trunk, or whether they are in line with the trunk. Therefore, if you use this lateral and medial, if you just apply it to A and B here, if you go by the distance between the midline and the point, these two distances appear very same. So this using a lateral and medial will not describe the position of A and B enough, or it will not describe it properly. Therefore, you use a different method. You take the site or the position at which the place at which the limb is connected to the trunk. Now here the upper limb is connected to the trunk to the shoulder joint, through the shoulder joint. Therefore, you can say A is more closer to the shoulder joint than B. So the terminology that is used is A more proximal to B. A more proximal to B, and B is distal to A. So whatever that is away from the attachment of the limb to the trunk is called distal. Whatever that is more closer to the attachment is called proximal. So A is proximal to B and B is distal to A. That's how you use these terms, proximal and distal. Now when it comes to lower limb also, the point of attachment is here at the hip joint. Therefore, A is more closer to the hip joint than B, and therefore you call A is proximal to B. A is proximal to B, or B is distal to A. Same whether it's upper limb or lower limb. Then this pre-axial border and post-axial border, not very frequently used, but if you stretch your, if you put your hand like this, if your arm is put like this, the side of the thumb is called pre-axial border, and the opposite side, the little finger side, is called the post-axial border. This can also be called, the thumb side can be called radial border, and this side can be called ulnar border. Radial border and ulnar border. So this pre-axial, post-axial borders can be also called radial and ulnar borders. Remember that point. Then when it comes to movements, now if you take the upper limb, any movement that moves the upper limb away from the midline, is called abduction, abduction. And any movement that brings it towards the midline, or you can call, brings it towards the trunk of the body, is called adduction. You call it abduction and adduction. Okay. So adduction is bringing it towards the body or the midline. Abduction is taking it away from the midline or the trunk. Same with the lower limb. So if you move the lower limb like this, that is called abduction, and move it this way, it's adduction. So that abduction and adduction is happening in a joint. Now here, this abduction and adduction is taking place at the shoulder joint, and here it is taking place at the hip joint. There are certain joints where you cannot do abduction and adduction well. Now when it comes to the elbow joint here, it's not almost impossible to do abduction and adduction at that joint. So remember that point always when you say abduction and adduction, they are referring to a joint as well. Now in the knee joints also, it's not usually, you don't do abduction and adduction, but you can do other movements. Then flexion and extension. Flexion is the movement that carries the limb anteriorly and bends it. So this is flexion. And extension is the opposite movement that carries the limb posteriorly and straightens it. Now this is true for most of the joints in the body, except for few joints. There are few different differences in certain joints. Now, okay, elbow joint or shoulder joint, you can easily apply it. Or hip joint, you can easily apply it. Wrist also, you can easily apply it. Wrist flexion and extension, you can easily apply it. But when it comes to certain lower limb joints, during development, lower limbs rotate medially, and the joints that are on the anterior side came to lie on the posterior side. Therefore, when it comes to the knee joint and the ankle joint, especially because the ankle joint, the foot is at right angles to leg here, the flexion and extension are different in these joints, knee joint and ankle joint. Now, in the knee joint, the movement that the movement that flexes the joint and bends the limb posteriorly is called flexion. Now this is this is hip joint movement. When it comes to the knee joint, this movement, now if your knee joint is like this, this movement is called flexion, that way, and this movement is called extension. It's the opposite. But here it's shown the hip joint, flexion and extension, the same definition. But this joint, flexion is this way, extension is the other way. And when it comes to the ankle joint here, this movement where the foot, the toes are brought upwards is called dorsiflexion. And this movement that way is called plantar flexion. Dorsiflexion and plantar flexion. So you will learn these things when you do the lower limb. But abduction and adduction are the same as I said before. Then circumduction. Now a joint like shoulder joint or hip joint, to some extent, hip joint is not as freely mobile as the shoulder joint. A combination of abduction, adduction, flexion and extension at that particular joint is called circumduction. So it's not rotation, it's different. Rotation is different from circumduction. Okay, circumduction is a combination of abduction, adduction, flexion and extension of that particular joint. Now in this case it is the shoulder joint. Then this rotation and rotation is actually along the long axis of the limb. Now this is the long axis of the lower limb. So along that long axis, if the limb winds medially, you call it medial rotation or internal rotation. If it winds outwards, you call it external rotation or lateral rotation. So same with the upper limb, you can rotate the upper limb at the shoulder joint medially or laterally, or internally or externally. Medial is equal to internal rotation. Then the pronation and supination. When it comes to the forearm, if you take your forearm in the anatomical position, if you remember the anatomical position, in the anatomical position, when the palms are looking forward, then the forearm is said to be in the forearm is said to be in the the supine position. Forearm is said to be in the supine position. So that is this one, supine position. And you can pronate it, you can rotate the palm so that it lies, if you are in this anatomical position, you can rotate it backward so that the palm now looks towards the back. Palm now looks towards the back. And that is called pronation of the forearm. So this supination and pronation are taking place below the elbow joint. They are not at the elbow joint. Elbow joint is somewhere here. So this is at the distal and proximal radio-ulnar joints. There are two small joints called distal radio-ulnar joint and the proximal radio-ulnar joint. So these two joints, there is rotation of the radius around the ulna, giving rise to this supination and pronation. Then when it comes to the trunk, again, you can describe the same terms. You can either flex the trunk this way or extend it, or you can do lateral flexion to the two sides, or you can do rotation, left side or right side rotation along the long axis of the trunk. That's another term that we use. Then this superficial and deep. Now superficial means more closer to the skin or the outer surface of the body, and deep means away from the skin or the outer surface. Now if you take, say if you take your limb, say if this is your forearm with your thumb and the other fingers here. Now this is the skin here. So you get the bones inside and muscles attached to these bones. So one can say that the muscles are superficial and the bones are deep. Or there is deep fascia superficial to the muscles here under the skin. One can say this is the deep fascia is superficial to the muscles. Or muscles are deep to the superficial fascia. Or you can say deep fascia here is deep to the skin. So you can use, these are all relative terms. Based on your preferences, you can use these terms freely. So these are the main terms that I wanted to describe in this lecture.